slide is not on the screen.
Oh, it's not in the screen. What happened? Wait. Okay. Where is share? Okay. Share. Okay. Is it in the screen?
No.
Not yet.
Not yet.
Yes, not yet.
Huh? Why?
Yeah, no. Not sure.
Okay. Okay. Desktop. Okay, this one closed.
Okay. That's on.
Okay. So, where is the second case? Okay. Oh. Okay?
Okay.
Okay. Okay, this one is actually the part, I mean, section of breast, not all the breast. Okay, so what do you see? Where is the tumor? Okay, this area is the breast tissue. You see the fat tissue, fibrofatty tissue. So what do you think the tumor where?
The black part down there.
You mean this?
To the left of it.
This one?
Yes.
What about this? The whitish color?
The part which does not look well defined is the tumor. Yeah, all around there.
This is the tumor actually. Can you see? It's irregular actually. Can you see this area? The more whitish?
Yes.
Actually,
Yeah.
this one necrosis. Okay. There is another case. See, this is the breast. Okay, this one is the nipple, and this is the skin coverage. And this is nipple. What do you think?
Okay, the white thing.
Is it this?
The white. Is
This
it
one?
fibrosis?
This?
Yeah.
No, this is fibrosis actually.
Yes, okay.
The tumor there.
Wow.
That one very, very whitish area is a fibrosis. Okay, the tumor, a bit grayish is the tumor. Can you see the tumor is not well circumscribed? Can you see the area there? Here is the invasion actually.
Vision.
Is irregular. This one is lymph node, the axillary lymph node. Also, see the same part. This one is already removed from the axilla, so lymph node is involved by tumor. Okay. So what happened to the nipple is inverted or retracted. Why? Because you know this fibrosis is pull the nipple in of inflammation and fibrosis, pull the nipple inward. So why it is inverted. Okay. And this one actually we already have taken a section from nipple to see whether the tumor is involved in the nipple or not. Okay. So how to describe this one? The color we said.
Grayish.
Yeah, gray, whitish tumor. Usually, infiltrating, have irregular border or infiltrating border. Is measuring about 2 by 2 cm, isn't it? The consistency, we said it's very important to say the consistency. Actually, consistency in fibroadenoma is firm. Okay, here it has gritty, and when we cut, we feel the gritty sensation. It's not very firm. It's necrosis is soft in cutting. You know, when I cut fibroadenoma, it's very firm. It's difficult to cut, but in tumor, it's easy to cut. In malignant. Okay. Okay. So our case. Okay, where is our case?
Doctor, what was the measurement?
Sorry? Measurement 2 by 2, I
CM.
think. This one. CM, yeah. Okay, can you see the screen?
Yes.
Okay. Okay, look at here. We said this is the normal breast tissue. See this area. Few ducts, okay, within fibro-fatty tissue. Look at the ducts, very clear, the ducts. They are lined by benign epithelium and the myoepithelial layer. Okay. Okay. Have you seen the normal area? So where is the abnormal area? Okay, I will move and tell me where is the abnormal area.
There.
Is this?
No.
Is it this?
Up. Yeah, this. The
This one?
long. No, this.
No, lah. It's still normal also. See, they are lined by 2 epithelium, still duct. Okay. What about those? Can you see the difference? Hello?
Yeah, but here you
Yeah.
can't identify very well.
So it's undifferentiated, not well
See,
differentiated.
that's how is it? Polymorphic cells, can you see? Polymorphic, what else? Hyperchromatic.
Automatic.
Okay, just look at the malignant. This is malignant cells, see?
Ooh.
They have prominent nucleoli. Inside the nucleus, there is nucleoli. See how the variation in the size and shape also. They have irregular nuclei also. Look. Okay.
What about the mitosis?
Yeah, mitosis there. This is mitosis. There is a lot of mitosis in this slide. You just move and look at and tell me where is the mitosis. This is mitosis. See? Okay, here. Oh, can you see the mitosis? This kind of which type of mitosis?
Bipolar.
Yes, bipolar. How many mitosis? How we can count the mitosis? This kind also we call this also mitosis. How many mitosis? I mean, how we count the mitosis?
Look at the nucleus.
We need to screen 10 high power field to count how many mitosis. This is mitosis. This one is mitosis. See, also this mitosis. This unipolar. Okay. What else? See, look at this. How is the nuclei very irregular? Okay. Remember which grade this one? How we grade? See, this one is mitosis. Look. This is unipolar. Can you see the mitosis? see the border is irregular. I mean, sometimes you can find the nuclei very dark, but it's not mitosis. You have to differentiate between mitosis and the like this nuclei. Okay, because the mitosis, you can see they have a regular border. Okay, so you agree with it is infiltrative? Are you agree?
Yes.
Can you see the infiltration? This is kind of infiltration. How we know? Look at the stroma. What happened to the stroma? Can you see those small? What are those small cells?
Fibroblast.
Do you think fibroblast? Fibroblast is this. This one is what?
Lymphocyte. No.
Yeah.
Lymphocyte.
Plasma cell. So is inflammation. The surrounding tissue is inflamed. It is, we call this desmoblastic reaction against the tumor, because, tumor also when invade the underlying tissue is like a foreign body, So the immune system will be reacted and also try to invade the tumor. So we call this desmoblastic reaction against tumor. Okay. See, can you see the irregular border of this strand of tumor? Can you see this? Can you see that?
Yes.
This is invasion, This kind of invasion. Even those small. Can you see any boundaries between those cells? I mean, the ducts, or like, remember that one of our ducts have myoepithelial? No. Can you see already invading the surrounding tissue? Usually the myoepithelial layer is lost or gone in malignant, because myoepithelial is active. Later.
Doctor, we can't hear you.
With a regular and hyperchromatic is nuclear. Yeah.
Doctor, we can't hear you
We can't hear you.
clearly.
Lagging. Okay.
Bad network quality.
Okay. Just few minutes. I will.
I think it was the mic. Hello?
Can you hear me?
Yes.
Yeah.
Hello?
Hello, yeah.
Yeah, we can hear.
You can hear. It's not lagging.
No.
Okay. So we said this is mitosis, okay? And this one, see the difference? This one is hyperchromatic nuclei. But these cells, the nuclei is vesicular. So we can see the nucleoli. Vesicular means you cannot see the chromatin very clear. Okay, you can see only the nucleoli. Understood? Hello?
Yeah.
Yeah.
Okay, so how we grade this? Remember the grading? On Friday, how to grade the ductal carcinoma? So I will move and tell me how to grade. Have you remember how we grade the ductal carcinoma of breast? Anyone?
It's by looking what about the
How to grade?
you have to look at the tubular glands and see if they're greater than 75%, and then within the table you gave us.
How to grade? What do you think this one is? Which grade? See, look to this. This one is what? This one.
Mitosis.
Yeah, mitosis. This one, I think, tripolar.
We can give it 3.
This one, look at this. Also, mitosis like star shape.
So doctor, the ones with very darkly stained chromatin, or like the nucleus is basically the mitosis.
This is the nuclei in mitotic phase, but abnormal mitosis.
The surrounding cells are the polymorphic cells, right? With the polymorphic nucleus.
You mean this?
No, the surrounding cells.
This one?
Which appear a bit clear.
Is this? This one you mean?
No, like the cells around that.
This one also this malignant cells? Beside it. How to grade? We said according what?
To the number of glands, the mitotic figures.
And?
Nuclear polymorphism.
Yeah, nuclear polymorphism. Okay. How many tubule here? Do you see tubules or glands? How many? How many? How many? Maybe this one gland, isn't it? Maybe this one gland. So, what do you think? How many? It is abundant, a lot?
Yeah, a lot.
Abundant.
A lot of glands.
I don't think there's a
Yeah.
lot of glands.
It is abundant.
This may be. So that means you think in this tumor is more than 75?
No, I wouldn't say more than 75.
What do you think?
Say 25 to 50.
Do you think?
I think it could be 75.
I cannot see a lot, you know. This is the
Less
tumor.
than 35.
Maybe this one. Maybe, can I see this? No, it's not a gland. Maybe here. Less than 10 even, you know, according to this tumor. So which point we have? Remember, I can show you the, this one. Remember how we grade according to nuclear polymorphism, glandular differentiation or tubule, mitotic figure. Remember we said 3 to 5 to 9 points. 3 to 5 is grade 1. 6 to 7 point is grade 2. 8 to 9 is grade 3. Okay, so grade 1 will differentiate, grade 2 moderately, grade 3 is poorly. So how to grade? We said score 1, 2, 3, right? Score 1 more than 70 for the tubular. More than 75 is score 1. Between 10 to 75 is score 2. Score 3 is less than 10. Nuclear polymorphism, remember we said score 1 is mild. Score 2 moderate. Score 3 is marked variation or severe nuclear polymorphism. Mitotic less than 10 mitosis, score 1. Between 10 to 19 is score 2. Score 3 is more than 20. So can we see on those? So here, what do you see? For tubular formation, is
Less
it
than 10.
less than 10? So which is score?
3.
Score 3.
Score 3, okay. For the nuclear polymorphism, what do you think? Is it mild or moderate or severe?
We give a score 2.
Is it score 2? Remember score 3?
Okay.
See, for 2 we said normal open vesicular nuclear visible nuclei and moderate variable in both size and shape. Score 3 is often prominent nuclei exhibit marked variation in the size and shape, occasionally with very large and bizarre form. Look at here. Okay, look at this nuclei, how's it?
Large and bizarre.
Yeah, and this one, and you can see nuclei. See, is it moderate?
No,
Is
it's
it moderate?
worse than moderate.
Yeah, it's severe. Look, there is marked variation in polymorphism. Is markedly polymorphism. Is so which is score?
Score 3.
Yeah, score 3. So for mitosis, okay, mitosis we have to move 10 high 10 power.
Mitosis.
Yeah, so we have to increase until 40. This is 40. Yeah. We said 10 high power field means you increase the power until 40, right? Can you see the 40? Yeah, 40.
Oh.
Then move 10 times. So, for example, but not to choose the area which mitosis is less and move around there, and some area very high mitosis. So you have to find first where is the area they have mitosis. Then you move there. Okay, low power, maybe I can, which area we can choose? This area, okay? I can see here a bit mitosis there. So we can increase the power. See, our power increase, 40. Okay, so we can move here. How many mitosis in this field? I cannot see. Also, I cannot see. Look at the nuclear houses, it's very big. So now we move already two fields, isn't it? And this is 3. So 1 in 3. 2 in 4. So I cannot. I don't think we are here. We are in correct area. Maybe we start here. Okay. Okay. So 1 in 1. Right.
Doctor, in this pleomorphic cells,
No, this is not in 1.
no, not that one, the ones around, the very large ones. Can you show us the nucleus?
This is the mitosis.
Yeah, not those ones. I mean the ones around.
This one.
Yeah, the metastatic, yeah, not those ones, the other ones. Yeah, these. Yes.
This is the nuclei is very irregular. See the nucleoli there, vesicular nucleus. So one in
Doctor, where's the cell? Is that the nucleus? Is that huge?
2 in 2. Three in 3. You know, you move like this way and you calculate. This one actually 3 in 3, 4 in 3. Also 5 in 3. 6 in 4. So we have to move like this and calculate how many mitoses. You know, actually this tumor is, the mitosis is more than 20. So 3 plus 3 plus 3?
9.
9. So which grade?
3. Grade 3.
Yeah, grade 3. Understood? Okay, what is the prognosis of this tumor? Is it prognosis or bad prognosis?
Bad prognosis.
Bad prognosis, because you said the grade and the prognosis depend on what? Remember?
The grade.
Tumor stage, the tumor grade, the
Proliferation.
The
Proliferation.
grade, the type, the stage, isn't it? Also in breast CA, what other prognostic factor we do? The estrogen and progesterone, right? Receptor. Okay, no problem. Just because if you have, if this tumor, for example, have still express estrogen and progesterone, so the prognosis is good prognosis because because the patient can treat it by tamoxifen. Tamoxifen, this is a hormonal therapy. But usually most of the grade 3, some of them, they are not estrogen and progesterone receptor. But actually the important prognostic factor, we said the nodal metastasis. This patient have already axillary lymph node metastasis plus the grade 3, so it's bad prognosis actually for this patient. Okay, understood how to describe this tumor? We said sheets, isn't it? Sheets, those sheets, and also strand. Can you see those strands of malignant epithelial cells composed of large, isn't it? Large cells with irregular nuclei, hyperchromatic. Okay, and show polymorphism also, many mitosis. Tubular formation is less than 10%, and nuclear polymorphism show marked polymorphism, and there is high mitotic figure, maybe more than 20. Okay, also the stroma shows desmoblastic reaction. Okay. Understood how to describe? Hello?
Doctor, what reaction was it again?
Desmoblastic reaction.
Desmo.
Yeah, desmo. DESMO. plastic PLA, plastic STIC. Desmoplastic reaction means there is a lot of inflammatory cells there, and also reaction. This inflammation will be replaced by fibrous tissue. And remember, the nipple is retracted. Why? Because of this inflammation.
Inflammation,
Reaction.
That's fibrosis.
Okay. Any question? Any question?
Doctor, you said you can see sheets and strands.
Yeah, this is a strand. Remember, can you see this? Like strand, cord or strand, right? Can you see those? It's like strand of malignant cell. Sheets means they are wide sheets. Okay, like those. Can you see this? Wide strand. So we call these sheets. Sheets of malignant. This mass of malignant cells. Diffuse mass. Okay. Any question? In tumor, when we assess tumor, we have to have look at the blood vessel, whether there is tumor inside blood vessel or not, or inside the lymphatic tissue. Maybe I can show you some area of carcinoma in situ. Where is it? Can you see this? This is a duct, but filled with malignant cells. So this is a kind of carcinoma in situ. Okay, can you see those? The malignant cells?
Yeah.
Inside ducts. This is a duct already filled with the malignant, but still not invading to the surrounding. So that means the tumor actually arises from carcinoma in situ, then with time it is invaded. It's also a duct, see, filled with it, but started when it is irregular, started to invade the surrounding tissue. See? Here, see? Can you see this? This one already like disconnected from the original one and started invading the surrounding. Okay? This also, the irregularity means invading the surrounding tissue. It's not like the normals. Remember the normals duct, how is it? Can you see those normal ducts? They are round, they have this supporting myoepithelium, no invasion to the surrounding. Okay? Any question? Clear?
Doctor,
Yep.
I want to ask, like, how do you know if that is mitosis? Because sometimes I feel like I can't recognize if that is mitosis or not.
How do you know? Look,
We are recognized.
this one, the mitosis. See? This is the mitosis also. Here, mitosis. Can you see abnormal mitosis? This is also abnormal mitosis. Here, abnormal mitosis. See, this one, for example, this one, for me, I cannot consider not mitosis.
Mm-hmm.
You have to check with the, see, this how is the irregular boundaries. Okay.
Okay.
Here is also mitosis. I can see in low power. Usually, you know how to see the mitosis in high power field, 10 or 40, under 40.
Mm-hmm.
Even I can see in we still can recognize until 10, isn't it?
Yeah.
But more clear when we make it at 40.
Mm.
Okay.
Okay.
here also another mitosis, see? Unipolar. So, okay, any question?
Doctor, and those in the large malignant cells, how come you can see it clear, like as if it's clear?
Which one? You mean the vesicular? You mean the vesicular nucleus?
Yeah. How come it's appearing clear?
This is features of epithelial tumor. You can see vesicular nuclei containing nucleoli. See? You know the tumor which is become more severe when you see the nuclei is vesicular. This is, this one is related to the epithelial tumor. Some epithelial tumors showing the vesicular nuclei, like breast CA and also lung CA squamous. Also, you can see the vesicular nuclei. Some tumor didn't show the vesicular nuclei. Okay, this is we call vesicular nuclei. See, the nuclei is like look like it's not empty but less chromatin there. The presence of nucleoli. Can you see the nuclei there inside? Okay. Okay, how you know how to describe, right? Name this condition. We said infiltrating ductal carcinoma. Compare and contrast this case with fibroadenoma. How to compare?
Doctor,
Mm-hmm.
can you repeat what the condition was?
Infiltrating ductal carcinoma of breast. But if I ask you what is your diagnosis, you will say infiltrating ductal carcinoma grade 3 or poorly differentiated. But usually we say grade 3. Actually, why we said name the condition. Name condition means the diagnosis actually. But we still not using the diagnosis in year 1. But actually, the condition is what is your diagnosis? What is the diagnosis? Is infiltrating ductal carcinoma of breast grade 3. Okay? Compare and contrast this case with fibroadenoma in question 1. So how to compare?
Here there's infiltration in the
Jinx Sala.
tissue.
Reading of tissue.
Okay. Local invasion. Invasion?
Yeah, invasive.
Invasive. So in fibroadenoma, not invasive.
No invasive.
Okay. What else? The differentiation?
The cells are large and irregular nuclei.
Poorly
The number
differentiated
of
cells.
ducts.
Mm-hmm. Can you see the history also? History, we said the tumor grow in what's the duration?
6 months.
6 months. But in fibroadenoma?
1 year.
1 year.
So, the difference?
One is duration.
Faster.
Duration.
It spreads faster.
Hmm?
Oh, mitosis,
Perfect.
like high
The rate of growth. Rate of growth. Fibroadenoma is slow growing. It can, the same size, even 10 years or more than 10 years, same size, not increased. But if malignant tumor, it will be increased. So the rate of growth is slow in fibroadenoma. In malignant, I mean in ductal carcinoma is fast growing, isn't it?
Yes.
Doctor, can you say pleomorphic cells as well for this one?
And then the features of malignancy. Features of malignancy is what? Is the cytological changes, each polymorphism, hyperchromasia, mitosis, regular nuclei, all these things. But in fibroadenoma, we don't have all these things. What else is very important? I showed you in gross.
Mitosis.
Mitosis.
Oh,
No.
soft and this
We said the mitosis is not the hallmark differentiation between benign and malignant, because in benign we can see mitosis, like leiomyoma, we can see mitosis is acceptable.
infiltration into the lymph nodes.
Metastasis,
Metastasis.
because in this case we have, isn't it? We have the metastasis to the lymph node. Can you see this? This is the axillary lymph node. It's already metastasized. What else? In gross? What are these species? You said this necrosis, right? Got necrosis. What else? This one is poorly differentiated,
Yeah, poorly differentiated.
but a fibroadenoma
Well
will.
differentiated.
Okay. Paham?
Hum.
Okay. Can move to the third case. I feel those who in the group only Akmal I can recognize, Jana, and who else? What's the name?
Daniel Hakim.
That one who?
Nabil Azmi.
Acap. Ashraf Saimi.
Oh, nak
The
dengar.
rest keep quiet or they going to sleep or what?
Sleeping.
Underdog.
Only listening.
Play game, play
Only
game.
listening.
Underdog, doctor.
Doctor, I have a question. When we talk about infiltration, are we talking about infiltration to the fibromyxoid tissue or fibrofatty tissue in the breast? I'm confused about that.
There is fibroid.
I can't hear.
Hello.
Hello, doctor. I cannot hear you.
Okay, you can hear me?
Yeah.
Okay. See,
No, oh no.
far away. Actually, I removed the mic.
Oh.
You okay? I will again mic.
Not so clear.
Now you okay? Hello. Can
Yeah, cannot hear clearly.
okay? Can you hear? Hello.
It's very faint, but we can hear, but it's very faint.
What do you want? To me remove the mic or not? It's clear.
I think can try the mic again.
I'm in. Hello. Hello. Hello.
Okay, can you hear me?
Yes.
Yes, but not so clear.
What I can do? Is it clear now?
Yes.
Yes.
Yes, yes.
Okay. Okay. We move to the third case. Boleh?
Alright.
Boleh.
Can.
Okay. The is third case or fourth case? Okay, the third case is a
Third case.
42-year-old lady complained of heavy menstruation of more than 1 year duration. As a result, she was also noted to be slightly anemic. Okay, hemoglobin is 10 gram. Despite medication, her menstrual problem did not improve. Her gynecologist advised for hysterectomy. So look at the gross specimen and try to identify the organ. Describe the abnormality noted. Okay, Okay, what is the organ here?
Uterus.
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 Can you see? This is the uterus and this is the cervix. Okay.
Yes.
Okay. What happened here? What is myometrium and endometrium? This one is what? Can you see? This is the rim. The gray whitish there.
Yeah.
This is the myometrium actually.
Oh.
This is the endometrium. Can you see this is the area this?
Yeah.
Okay. So what happened here? Enlarged or there is tumor here?
Tumor necrosis.
Can you see the tumor there is compressed the myometrium.
Yeah.
We said the benign tumor is growing by what? By compression of the normal tissue, right? This is the same thing. Is growing by compressing the normal tissue. Okay. This tumor we call leiomyoma or fibroid. In gross we call fibroid. So how many fibroid here? This one. How many fibroid here do you see?
3.
3.
3. Yes. This one and this one and this one. So this one we call intramural. Intramural means inside the myometrium. Actually, but even this we call subserosal, but the tumor is arise actually from myometrium, from the muscle. But why we said subserosal? Because it's it's protrude to the serosa. So we call subserosal. Also, this is subserosal, but this one still within the myometrium. Myometrial muscle. So we call intramural, means inside the muscle there. Okay. So how to describe this? Well circumscribed, right? Well circumscribed means rounded. Well circumscribed gray whitish tumor measuring blah blah. Okay. The cut surface is homogeneous or heterogeneous?
Homogeneous.
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 Okay. And also the consistency is very firm. There is another, see, like, can you see this? This subserosal. Don't say subserosal means is arise from serosa. No, it is arise actually from myometrium, but it protrude through the serosa. So we call subserosal. Okay.
Right, doctor.
Okay, this one submucosal. I don't think I cannot see well circumscribed. It just pull it. Don't. This one is not leiomyoma actually. I don't know wait. Okay. For our case, for the lemma. Okay. Okay. What do you see here? Okay. I will show you the norm. What do you think the abnormal area? Is it here? Hello?
The circular part, the one that looks round.
Yes.
On the bottom left, bottom
See,
right.
you can
Yeah, right.
identify the abnormal area is well circumscribed.
Well
area,
circumscribed. Yes.
First we can see the normal area. See, this is the normal area. See, we can increase. This is the smooth muscles. Can you see? The smooth muscle have elongated nuclei. Can you see? Bundle of smooth muscle fiber with elongated nuclei. Can you see any?
Doctor, we can't hear you.
Hello?
She muted the mic. Doctor, you muted your mic. Hello?
Hello? Hello?
Doctor, unmute. You muted.
Doctor, we can hear you.
Okay.
Hello?
Yes, hello.
Hello?
Yeah.
Hello?
Can you hear me?
Not so clear.
Yeah, but not clear.
Not clear. Hello?
Alright, now we can hear.
Yeah, that's better.
It's better.
Yeah.
Okay, thanks. You know, بس صوت يا صوتهم يعني حباني. آمين. Okay, we continue.
Yes.
Do you want break or we can continue? Hello?
Let's just continue this question.
Just continue.
Question
Okay.
4 and delivery.
Okay, so this is that area is, we said normal, we can go to the abnormal area, this one. Okay, we will see. Is there any difference? Can you see any difference? Is there?
No.
No, same. isn't it?
Well
So-
differentiated.
Yes.
Yeah, that's mean the same is well differentiated, no difference. Okay. This how to describe. We said interlacing. Can you see interlacing bundle of smooth muscle? Can you see this smooth muscle fiber like this, and other one is coming the same way. So we call interlacing or decasseting. Okay. Interlacing bundle of smooth muscle fiber. They are composed of elongated cells with elongated nuclei. No polymorphism, no atipia, no hyperchromatic. Mitosis, you know, in leiomyoma is acceptable until 5 mitosis is okay. We still say benign leiomyoma. Okay. So why we said mitosis is not the main difference between benign and malignant, because in leiomyosarcoma, the difference between leiomyosarcoma and leiomyoma is what? Many criteria. First, necrosis. Second, atypical cells. Atypical cells mean the features of malignancy, hyperchromatic, and the mitosis should be more than 5 or more than 10, okay, plus other criteria. Even if we found 10 mitosis and no polymorphism and necrosis, we still say proliferating leiomyoma, you know. So we said the mitosis is not the main difference between malignant and benign. Okay. See, look at here, no atipia, no atypical cells. In this leiomyoma, I don't think we can find a mitosis. Maybe this mitosis, one mitosis. Okay. I think that's all.
What does atipia mean?
Atypical cells mean is malignant cell, the features of malignancy, which is hyperchromatic nuclei, irregular nuclei and irregular cells, polymorphic cells. This is mean atypical cells.
Doctor, doesn't polymorphism mean the same thing as irregular?
Yeah. Polymorphism means varying size and shape. Okay. Can you see this is the interlacing bundle of smooth muscle fibers? Okay. Some areas shows like fascicles, which is like is the type according to the cutting of the tumor. Can you see this is fascicles? Okay.
Doctor, can you explain interlacing bundles again?
Okay, interlacing mean they are decasseting. Okay, I can show you the how is the fascicle. Okay, look at here. This bundle of smooth muscle coming like this way. I mean running at this way, and the other one is coming and the cross, isn't it? So we call this interlacing. Okay, understood?
Yes.
Okay, that's all in the leiomyoma. Okay, the question is what? Look at the gross specimen where we said well circumscribed fair mass with whorly pattern, subserosal intramural fibroid. Look at
Homogeneous.
homogeneous cut surface, gray whitish. Okay. Look at the microscopic slide of the mass. We said interlacing bundle of smooth muscle fiber, well circumscribed, and mitosis less than 4 certain high power field, variable amount of intercellular fibrous hyalinized stroma, Maybe this hyalinized stroma, we can show you this. Some area hyalinized. You know, we consider this hyalinized stroma. Okay. Here also a bit hyalinized stroma. You know the hyalinized tissue. When we saw the pink color.
Hyaline connective tissue, is it?
Yeah, it's type of connective tissue actually.
Oh, hairline cartilage.
Yeah, it's not cartilage. This hyalinized tissue. You can see more pinkish color there around. This is hyalinized stroma. Okay.
Doctor, can you please repeat the name of the stroma?
Hyalinized stroma. HYALINISED. Hyalinized stroma. Okay. Name this condition or give your diagnosis.
Leiomyoma.
If I show you this one, wait, this one, we still say leiomyoma.
Leiomyoma.
We say leiomyomata. Mata means many. Leiomyoma. 1, 2, 3. More than one, we call leiomyomata.
Leiomyomata.
Yeah. I mean, if I give you the question this because many leiomyoma, you said leiomyomata. But if I give this one, you don't know whether it is 1 or 2 or 3, isn't it? So leiomyoma.
Mm-hmm. Yes.
Doctor, can you go back to the gross picture 1 second?
Okay, back to gross. Yep.
You know, there is a gap, like if we go up the cervix, there's this gap, like a line, like a slash.
This one?
Yeah.
Endometrium.
We said endometrium. Actually,
Okay, so this big fibroid is in between the endometrium and the myometrium.
See what's happened. Actually, endometrium should be in the center, right? Like this one.
Yeah.
Like this one. See, this is endometrium. But because of the growing fibroid is compressing to the endometrium to a side, this to one side, and also compress the myometrium.
Okay.
Mm-hmm.
And doctor, this is a benign, right?
Yeah, benign. You know, if the lady pregnant, what happened? It will be aborted because the tumor is growing and compressing the, the endometrium and the embryo. You cannot grow. The embryo cannot grow. So most of the ladies, they come with infertility because the embryo cannot grow. Infertility, okay?
Alright then.
Okay. So we back to this one. Okay. So what's this condition? We said leiomyoma.
Leiomyomata.
Okay. In this condition, benign or malignant, list the
Benign.
features that support your conclusion. Okay.
Well differentiated,
Well differentiated.
non-invasive,
Yeah.
non-invasive, no hyperchromatism,
Yeah.
no pleomorphism.
Uh-huh.
I think that's it. Same thing as just now.
Well circumscribed, right?
Yes.
One of feature. So no invasion means. Also, is it metastasized? No.
Oh,
We said the main features to see no metastasis, no invasion. This is the important things. Then you come with other things. Okay, no atibia, no necrosis, pheomatosis. Pheomatosis in leiomyoma is acceptable. Okay. Okay, fourth case. Fourth case is a 40 Is it okay? The third case, no question.
No.
Okay. Fourth case, a 49-year-old man presented with history of indigestion, feeling bloated after eating, mild nausea and loss of appetite. He had lost 10 kilogram body weight in the last 3 months. Following esophageal-gastroduodenoscopy and biopsy, he was advised to undergo partial gastrectomy. Okay, look at the specimen of the stomach and describe what you see. Okay, you can see there. Okay, can you tell me what happened here?
Patient.
Abdullah around. Abdullah.
Yes.
Where is the tumor?
I think it's loss of Ragay.
Where is the tumor? Here, down or up?
The gray whitish area.
Where, up or down?
Up.
Up. Yeah. Can you see this is the tumor? Look the tumor. Okay, we have to see the wall. Can you see the wall of the stomach?
Yes.
So what happened here? The tumor, see the whitish color is already
Compressed.
not compressed, invading until serosa. Can you see this is the fat tissue? So the whitish color invading the whole layer. Okay. So this is the stomach. Can you see? We call this lesser curvature. Okay, and this one greater curvature of stomach. Okay, so the tumor were in the lesser curvature. So this is the omentum or the peritoneal covering, this one. Usually why we remove the stomach with this peritoneum, because we have to find the lymph node, where is it involved or not, because usually most of the lymph node is present around the omentum or peritoneum. Okay, so how we describe the tumor is gray whitish tumor invading the wall of the stomach or the lesser curvature of the stomach. Okay, so we can go back to our slides. Slide, where is our slide? Oh, before I show you the slides, I want to show you first the histology, normal histology of the stomach. Okay, look at the normal histology of stomach or the gastric. We have the mucosa, okay, submucosa, okay, muscularis propria, and the outer layer is the serosa. Okay, now have a look. So can you see the mucosa is composed of glands, isn't it? Okay. We have muscularis mucosa and muscularis propria. See, muscularis mucosa is this small rim down of the below the mucosa, and then submucosa, then muscularis propria. Okay. See, in submucosa we can see loose connective tissue plus the blood vessels. Okay. Look at this. This is the mucosa. How is the gland? See the glands, how is the benign gland is composed of one layer of columnar epithelium and basal located nuclei. Can you see? Okay?
Okay.
Okay, this is the normal one. Okay, look at our slides. Okay. Okay, what do you think the abnormality were? This area or this area? Which
The
one?
right one.
This one.
Yes.
Okay. Okay. Wait, first we go to this area. I cannot. Okay. What happened to here? Okay. See, this is the glands. Okay, what happened to the gland here? What do you think the abnormality here?
Necrosis.
Is it necrosis?
It's become elongated.
No.
When you
Okay.
get
Okay, compare this gland with this gland. This is the normal gland, right?
yeah, regulation.
Oh,
Yeah.
so what is the difference? Mm-hmm.
Many layer.
No lah. There's obvious changes.
Is it become more elongated?
Metaplasia.
What is metaplasia?
Change of
mature cell to another mature cell.
No lah. It got metaplasia, but what type of metaplasia?
Columnar to squamous.
This is squamous? No lah. Still columnar. It is columnar, still columnar. But what is the metaplasia here? Titiana? Where is Titiana? Titiana? Hello? Are you around? Titiana? Not around. Damia?
Yes.
Yes, what do you think? Which type of metaplasia here?
Goblet cells.
Yeah, very good. Can you see this, the goblet cell?
Yes.
Can you see, have you seen here in the normal stomach? Normal glands, I mean? Do you see any goblet cell here?
No.
The goblet cell. But present in the in these glands. So this gland got goblet cell. That means usually goblet cell. Where do you see goblet cell?
Respiratory tract.
No, in the intestine.
Yeah, intestine.
Intestinal glands. So this is metaplasia of the gland from columnar to goblet cell. It is columnar, but intestinal type of the columnar epithelium. Okay, they have goblet cell. In the stomach gland, no goblet cell. Okay, so there is goblet cell here in this area. So do you think this even gland, is it normal? What happened to nuclei? What do you think?
Paleomorphic, hyperchromatism.
Yeah, hyperchromatic and irregular. It means dysplasia. So what happened to the gland? First, they got this kind of metaplasia. Okay. Then with time, they changed to dysplasia. Okay. See all these dysplastic glands. Okay. So what do you think what are these inside here? Those inside the gland. What else I can? Can you see this like something inside?
Yeah.
What do you think?
Mucus.
Is it mucus? I think it's not very clear there.
Is it?
Why I just look at the lumen. Why I have to look at the lumen? I think that one is clear. I mean, it's not so clear, but it's okay. I can. Is it? I have to find the blood cell, red blood cell inside the gland, the lumen. This patient have what? She's complaining of what?
Indigestion.
What else? Nausea. So what do you think the patient have actually? Long time. She has what? Okay, no problem. So if the patient got metaplasia, then dysplasia, there is something. Why she got metaplasia?
There's some injurious stimuli. Is it the gastric acid? I'm not sure.
Yeah, gastric acid. Why the gastric acid is increased?
Lower esophagus reflux, maybe?
Due to what?
We talked about, is it lower esophagus reflux, something like that? I don't know. Whether the gastric acid goes to the bottom part of the esophagus.
Why? I mean, is not the problem here in the stomach inside? See, look at this plastic gland. Sorry.
Oversecretion of acid from parietal cells.
Yeah, there is oversecretion. What do you think due to what?
Infection.
Due to what?
Infection.
Infection of by what?
Helicobacter pylori.
Yeah, very good. So why I'm looking?
Yeah.
Remember, I told you what are these? Those inside the lumen.
Bacteria.
Is bacteria actually. That's a lie. Actually, in this slide, it's not very clear, but you know, I'm sure if they do the Wharton study, silver stain, it will be positive. They can see, we can see, you know, we can see the H. pylori by HNA slide. But I think this slide already a bit faded or not clear. Okay, so because of H. pylori causes inflammation of the, you know, of the stomach. Even, you know, H. pylori itself, the bacteria, is a carcinogenic. Yeah, is a carcinogenic. If not treated, it will causes transformation of the glands into malignant glands, like this case. This case, the patient has H. pylori. He got gastritis. With the time, long time, it causes, you know, metaplasia, then dysplasia, then transformation of the glands into malignant gland. Look at here, this area. We have seen the metaplastic and the dysplastic glands, isn't it? Isn't it clear?
Yes.
Look at the malignant here. See? Look. See? Can you see the malignant? This is the malignant gland. They are, see, look at this one. Wait. Actually, how is it? The malignant already invading the surrounding tissue, isn't it? And also look here. Can you see the malignant gland? How is it? They are irregular and branching. See, like cribriform. They filled with malignant cells, which is hyperchromatic, irregular nuclei. Look, the tumor is invading. Remember that this is the mucosa. This one, we said submucosa. See the malignant, how they invading the submucosa, and also they reach to the muscle layer, muscularis propria. Can you see there? This is the malignant one, malignant gland. And also where? It reached to where also? Can you see? It's already reached to the serosa. Okay, so which staging of this gland? Okay, this one you can see the tumor within the lymphatic. Can you see this is the lymphatic channel? So which staging of this? Duke stage A or B or C?
E.
C, because we already have the lymphatic invasion. So can you see the malignant gland is invading the mucosa, submucosa, isn't it? Submucosa, muscle layer, muscularis propria, and serosa. So this is infiltrating tumor. Okay, how to describe? Is it infiltrating tumor arise from mucosal layer composed of irregular malignant gland invading mucosa, submucosa, muscularis propria, and serosa. You can see the malignant gland is lined by malignant columnar epithelium displaying or show hyperchromatic nuclei, irregular nuclei, epidermorphism, mitosis. Okay, understood. See again, see how it is the branching irregular. Look at the normal glands there. Even the dysplastic gland is not like this. Look at the dysplastic gland. Dysplastic glands means they still not invading. Look, this dysplastic gland, but is not invading the surrounding tissue. Okay, see degree of dysplasia there, but still within the gland, no invasion to the surrounding tissue. You know, the mucosa usually composed of glands and lamina propria. This is the surrounding is lamina propria. Okay. See this area, no invasion, right? This area, no invasion, still benign. The malignant here started from here. Even this area is malignant, but the malignant how? They invading the lamina propria. Can you see those small I mean the malignant cells surrounding in the dispersed within the lamina propria. No proper gland around, isn't it? Also this one, look how is the irregularity. This invasion. Okay, but here is very obvious. This area we can see the invasion to the submucosa. Okay, submucosa we can see. He said muscularis propria already there, and the serosa. Okay, Understood? Understood?
Yeah.
Yes, yes, yes.
Doctor,
Yep.
that invasion over on the right side of the screen, is it the lymph node?
This one.
Yeah.
This is lymphatic vessels.
So it's already metastasized.
Lymphatic vessels, we don't know it is metastasized or not. We said if metastasized to other organs, we have to do a CT scan, right? Under microscope, we cannot judge is it metastasized or not. Yeah. Yeah. If D, we have to do the CT scan, MRI to see where is the tumor. Is it metastasized or not? But under microscope, we can judge until DUXI. When we report, if we don't have the report of the other like CT scan, we just see Duke stage C in under microscope, because we don't know is it in the liver, it is in the lung or brain, we don't know. Okay. How is the prognosis of this patient? Is it good
Doctor, I have a
or
question.
bad? Bad, because he got lymphatic channel metastasis or emboli. We call this embolus of malignant cells. Okay? Or tumor emboli or tumor thrombus. Okay? Can you see the lymphatic? This is the wall. Okay? And usually we said the lymph, we cannot see any, blood vessel or, RBC or something. We just see the, is clear. But here is already invaded by malignant cells. Okay? Yes? Any question? Also, this one is tumor emboli there.
Doctor, what does embolus mean?
Okay, embolus, what does mean? Actually, next week, not next week, this week, you will have the thrombus and embolus with Prof. Nani, but I can tell you means, if you have thrombus is composed of the constituent of the blood. The main things, the thrombus we said, is mass composed of component of the blood is like fibrin, white BC. They forming like a thrombus mass. They can occlude or blood vessels. And make what happened in the heart, myocardial infarction, cut off the blood supply, is due to atherosclerosis thrombus. So they can include the blood vessel. Embolus, part of this thrombus can be detached. Okay, and traveling to a small blood vessel and occlude the small blood vessels. Also, same thing. The embolus can be not only from blood; it can be from atherosclerosis, from air embolus. Can be what else? Can be anything. We said tumor emboli means a small part of the tumor is invading to the lymphatic vessels and they inside the lymph. We call tumor embolus. This one, remember in the invasion, mechanism of invasion that I give you in carcinogenesis? How they invade, they have to detach first from the tumor there. Then they have to dissolve the what we call the basement membrane. Okay, and then they go to the lymph or blood vessels, and they have to cover themselves with fibrin. So the immune system cannot recognize this as a foreign. and is not from our blood constituent. So they can travel, you know, this embolus, they can travel through the blood, okay, until it reaches the certain suitable area. And then they do the same thing. They dissolve the basement membrane and go out to the any organs, liver, brain, and they can grow as the original tumor. They can grow angiogenesis like that. Okay, understood?
Yeah.
Okay, so how to describe this? Already described. We said question 4.2. Look at the micro slide from the specimen. Describe your finding. Identify area of normal gastric mucosa. We already saw, isn't it? Intestinal metaplasia with goblet cell. Yes. Adeno-CA. Tumor emboli. This is the tumor emboli. Okay. Within vessels and lymphatic. Name this condition.
Adenocarcinoma.
Adenocarcinoma.
Gastric adenocarcinoma. Complete your arising from where? Arising from background of chronic gastritis with intestinal metaplasia. Remember? This area?
Yeah, metaplasia.
This area we said metaplasia and dysplasia. Can you see those? The goblet cells. See the lamina propria, how is it? They are infiltrated by inflammatory cells. See? Those inflammatory cells. Okay?
Doctor, is gastric adenocarcinoma consisting of background?
Arising in background of chronic gastritis with intestinal metaplasia. What is the prognosis of this patient, we said? Is it good or poor prognosis?
Bad.
Poor.
Poor prognosis. Why?
It reached the lymph nodes.
Metastasis.
We cannot say metastasized. We say because of there is a presence of tumor emboli.
Yes.
Tumor emboli in the lymphatic vessels. Because this one can lead to metastasis. Okay? Any question here? Is there any question?
No.
Clear?
Yeah.
Okay. Do you want break?
Yes, please.
Yes,
please.
Yes, doctor.
Yes.
We already finished this benign. You need to continue to the practical 7, or you want tomorrow? What do you advise?
Huh?
What
Advice.
do you want? I mean, what do you want? Continue the practical 7, or do you want tomorrow?
I think continue tomorrow. I mean, continue today.
Can. Okay. I don't have any problem. So you can
Break, doctor.
absorb because we have, you know, so